Yes.
And how much time I have? There are only few.
30 minutes.
Okay. Yeah. Uh, yeah. It's not moving. 1 second. Yes. So the first question: which of the following clinical factor will affect neutrophil count in newborn infants? Is it premature rupture of membranes when mother is afebrile, meconium staining with no lung disease, uncomplicated hyaline membrane disease, or uncomplicated transient tachypnea of newborn, or hemolytic disease? So, Dr. Kavita, I think you will have to coordinate with me because I can't see the chat box.
Yeah, I'll tell you.
Okay?
So, yeah, most of them are saying A, some are saying B.
Okay. So, the question looks very simple, but yeah, I can see now something happened. Somebody has
Wait,
shared the
is this?
screen.
Dr. Swapna, please stop sharing your screen. Okay. We'll do it afterwards. Yeah. We'll do it later.
Okay. Okay, so should I continue? Yeah.
Yes, yes, yes.
Okay,
So people
so
have answered A, some have answered B, and some have answered A and E.
we are talking about the clinical factors, these clinical factors affecting the neutrophil count, okay? And you can read the options carefully. We're talking about premature rupture of membranes where mother is afebrile, means there is no evidence of chorioamnitis, okay? It's just the rupture of membranes. The second is meconium staining is there, but there is no lung disease. The baby is not symptomatic. We are not talking about meconium syndrome. And the third is uncomplicated hyaline membrane is simple plain RDS, right? And the fourth is transient tachypnea of newborn. That's also plain transient tachypnea of newborn. And the fifth is hemolytic disease. So the first four are not going to affect the neutrophil count, and they do not need any kind of antibiotic treatment. Hemolytic disease, because the bone marrow is affected, is likely to cause because of the erythropoiesis or maybe aplastic anemia, okay, secondary to intrauterine transfusion, may affect the neutrophil count, right? Are we clear? It's very difficult. So the answer is hemolytic disease. The other four, the first four will not affect the neutrophil count. In hemolytic disease, you may see neutropenia.
Yes, I
Thus,
think 4 or 5 have answered E.
okay,
Correct
good.
answer.
Some, okay, sorry. Yes. So can just write in chat box what do you mean by bind score and where do we use this? What is the maximum score in this and what is the minimum score? And how do you interpret? So how do you interpret? I'll tell you because it's a long. I feel it was interactive. I, how do I see? So are they answering?
Yeah, so they're telling the correct long form of the. So everyone is saying bilirubin induced neurological dysfunction, bilirubin induced neuronal damage score. Swapna has answered. Minimum 0, maximum 9.
Correct. Okay.
So they all know that. Yeah.
Yeah, so this is bilirubin induced neurological dysfunction. So you do it in babies who are hyperbilirubinemic to know whether they are having acute bilirubin encephalopathy or not. Okay, so these are the different components. The cry pattern, behavior and mental status, and the muscle tone is checked. If the score is 1 to 3, then you know that there are subtle signs of mild encephalopathy, but you can continue with the intensive phototherapy. 4 to 6 means you have to intervene and bilirubin has to be lowered as early as possible, and 7 to 9 is advanced acute bilirubin encephalopathy and will lead some damage if you don't intervene early. Okay, so that is bind score. Okay, the next question: identify the investigation and interpret the finding. And what first management you are going to do in this? What's the investigation, interpret the finding, and what is one management? Even one management is enough.
Okay, so two of them have said AEG and one of them has said NST. And they said it is a seizure.
Okay. So should we continue with the answer?
Uh, yes. Yeah,
Yeah.
all of them have said AEG. They have identified.
Yeah, so this is amplitude integrated EEG. You can see the voltages displayed here, okay, and these are the waves. This is a compressed EEG over 6 seconds. So why is it neonatal seizure? Because you can see this is the amplitude and there is sudden drift. It is lifted upward, right? So these are called capping. Okay, so this capping, so you may have EEG where the upper border is this and then you have lower border just a cap. That's not conversion. You have to have drift in upper border as well as the lower border, that is cap, and this is electrographic seizure, right? So these are seizures. And what management? So you as we discussed in case, you can collect the samples, give calcium, magnesium and phenobarbital or levetiracetam as the first line anticonvulsant, right? So just a word about amplitude integrated EEG. So you have different interpretations. So what you have to know is where is the lower border and where is the upper border of this voltages, right? So if your lower border is at 10 and the upper border is at 25 or above 25, then it is called normal, continuous normal voltage. Okay, but if your lower border lowers to 5, then it is called discontinuous normal voltage. Okay. So if your upper border also lowers with lower border, then it is called continuous low voltage. And there is a flat trace if both borders are below 5 microvolt. Okay, that is how you interpret. This interpretation is important to assess the background neurological function of the baby as well as to decide whether this baby, specifically in case of HIE, it's very important to assess the background. Okay, so just this is a case. 16 days old male baby was referred for evaluation of bradycardia, but actually this baby was lethargic, disproportionately was hypotensive. This baby was born to gravida 3 mother, para 2, third degree consanguineous marriage, LSCS, birth weight was 3.1 kilo, was exclusively breastfed. On 16 days had sudden crash, and mother complained that the baby is sleeping, not moving a lot, and was lethargic. So on admission the baby was saturating more than 90%, heart rate was more than 100 beats per minute. Okay, so this was the echo. Okay, what specifically you see in echo? And this was his monitor. What is the likely diagnosis? A term baby, third degree consanguineous marriage, sudden crash, hypotensive, lethargic, sugar borderline. Look at this monitor. Look at the ECG trace. What is it showing? The ECG trace. Is it regular? Okay. Are they answering?
Yeah, we'll just wait for. They're taking their time. I think it's a tough one for them.
Third degree consanguineous marriage, male baby, exclusively breastfed, crashed on day 16, hypotensive, mildly hypoglycemic, lethargic with this ECG.
So 4 of them have said ventricular tachycardia, VT.
Ventricular tachycardia, tachyarrhythmias. Okay, very
And
good.
one of them, and they have given diagnosis. 2 of them have said Pompe's disease. One of them has said myocarditis.
Okay,
And one of them has answered heart block.
okay.
I,
Okay,
I
so
don't think
agree, difficult, but the catch is this baby was all right, right? Third degree consanguineous marriage, male baby, and hypotensive, hypoglycemic, and arrhythmia. Now where are we? Hypotensive, hypoglycemic, and ventricular arrhythmia. So male neonate crashing on day 16, day 17.
2 of them are now saying CAH.
Right. So this was the ECG. Now what does ECG what is it showing? Now when you talk about CAH, what is the probable diagnosis now? So how is the QRS complex? Narrow or wide? CH में क्या होता है इलेक्ट्रोलाइट abnormality?
They are mentioning hyperkalemia.
Hypokalemia. So what are the ECG findings in hypokalemia? So you have
Yeah,
so are they writing ECG findings in hypokalemia?
yeah, they're writing wide QRS and tall T waves.
Right, and sine wave in severe hypokalemia. So what's the treatment? So you stop the exogenous supplementation, whatever is going on. If IV fluids are going on with potassium, stop potassium. If there are medications, potassium sparing medications, stop that. If you are adding something, uh, KCL has been going on, that also you stop. Stabilize the cell membrane because this baby has got arrhythmia. So how do you stabilize? Give calcium gluconate, okay, in a dose of 1 to 2 ml per kilo. Translocate potassium intracellularly. How can we do that? The sodium bicarbonate 1 to 2 millicoulomb per kg over 5 to 10 minutes. You can start GI drip. How do we prepare GI drip? Anyone can write in chat box. How do we prepare glucose infusion drip? You can give salbutamol nebulization also and start K bind. Are they writing GI drip? Yeah, so many of them have written glucose in GIR, not GIR. We are talking about glucose insulin drip for hypokalemia. So simple formula, 10 unit of regular insulin in 100 ml of 10% dextrose at the rate of 1 ml per kg per hour. Okay, that is GI drip. Okay, now the next is a spotter. So this is a baby who was on full feed, a preterm baby, and then suddenly had abdominal distension and got ventilated. Okay, now you will see the video and you have to write this diagnosis. So, yeah, diagnosis and what's the treatment.
So some of them are saying chylous ascites, whereas some of them are saying chylothorax.
Okay, so I spoke about abdominal distension, so it has to be ascites. So yeah, so it is chylous ascites because it's milky fluid which is coming out through the ascitic tap, right? And what's the treatment?
So we have got 3 of them saying octreotide.
उसके पहले कुछ होता है ना important?
हाँ, तो टैपिंग एक जन ने लिखा है, टैपिंग करो पहले.
उसके भी पहले कुछ important रहता है. What is it? Keep baby NBM, right? You don't load the baby with proteins, enteral proteins. So the fat, not proteins, fat. Okay. So what do you give? So you keep the baby NBM, TPN, aggressive TPN. Okay, octreotide if the baby does not respond to conservative management, and a MCT based formula. Okay, okay, so identify this chart. And how is it similar to WHO? And up to what gestation age this chart can be used? Are they writing?
Yes, so some of them have written, most of them are writing Intergrowth 21
Okay.
chart, and but the gestation age, they're writing 40 weeks, and then some have written 64 weeks,
Yes, it is
44
60.
weeks.
Yes, it is 64 weeks. It is intergrowth, and the similarity is they are multicentric growth charts based on the prescriptive standards, right? So that's the similarity between WHO and intergrowth. Now the next question is, where will you plot the growth of baby born at 28 weeks of gestation and now has come to high risk clinic for follow up, and baby is 5 months? So on a WHO growth chart, where are you going to plot, at what age are you going to plot this baby's growth? The baby is currently 5 months. I have WHO growth chart with me. So the baby's chronological age is 5 months. This is an extreme preterm, 28 weeks. I'm sitting in OPD. I have WHO growth chart. Where should I plot this baby's growth? At what age?
So they're writing corrected gestational age at 2 months.
Okay, perfect, very good. Okay, so you don't plot this baby's growth at 5 months, but you have to correct the gestation age, and that is you have to plot this the baby's growth at 2 months of gestation. Correct, perfect. What is this? Okay, what is the diagnosis? I hope the video. And what has happened? See what has happened. What's the diagnosis?
Yeah, so most of them answered SVT
Perfect.
and
And
adenosine.
what has happened? It is reverted to normal rhythm because of some intervention. So what intervention has been done? So what is the treatment of SVT?
So they've written adenosine. One of them has written amiodarone.
And if the baby is hemodynamically unstable, then
DC shock.
specifically DC shock or something else, you do synchronized cardioversion. Okay, so
Yes.
what joules are you going to do cardioversion? What joules are you going to use if you want to cardiovert the baby? And what's the dose of adenosine?
So they're writing 0.5 joules per kg, and some are writing 1 to 2 joules per kg.
Right. So you start with 0.5 to 1. And what's the dose of adenosine?
So they're giving it as 0.1 milligram per kg.
And how is it administered?
So they're all writing rapid push with
And
three-way cannula and rapid push and fast bolus.
yes, push and flush
Two-way
technique.
flush technique. Two-way flush technique. Pankuri's had answered it.
The push and flush technique. Okay. Yeah. So yeah. So this is eighth question. So a male baby born to a priming gravida by emergency cesarean section at 34 weeks of gestation. Baby did not cry after birth. Required resuscitation. Birth weight was 1.5 kilo. ABG showed within 1 hour severe metabolic acidosis. pH was 7.2, lactates were 10. There was third degree consanguineous marriage. Okay, this baby is born by third degree consanguineous marriage. On admission, baby looked severely pale. Okay, so the baby's hemoglobin was 5. The baby was investigated. DCT was negative. There was no abruptio placentae in mother. There was no obvious oozing from anywhere in this baby. Retic count was 7, and the lab person called about this slide. So what is the likely diagnosis? These are real cases.
So they're all answering hereditary spherocytosis.
So, so this baby is anemic at birth. No history of bleeding from anywhere. Obvious history of bleeding from anywhere. Retic is 7 on day 1 at birth. DCT is negative. Spherocytosis, retic will be normal or low or high?
Yeah. So Garima has said it will be high.
Correct. So here the retic count is normal, right? So what is the likely diagnosis? Look at the slide. Look at the smear. What is it showing?
Now we got answers of thalassemia, alpha
नहीं
thalassemia.
नहीं 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 नहीं. Alpha thal baby will be hydropic, no? Okay. So so let us go there. Okay, so any baby, when you see that the baby is anemic, what you have to see is whether this is a hemolytic anemia or non-hemolytic anemia, correct? How would you know this is hemolytic or non-hemolytic? You have to see the retic count. Retic count on day 1 is 7, and with every day it drops by 1 to reach 1 or 2 and on day 7 of life. The 7 on day 1 is normal, correct? Once it is, so if it is, so in this patient, our patient, this is non-hemolytic anemia. But if it is hemolytic anemia, the next step is you evaluate whether it is immune or non-immune. For immune, you do DCT ICT, which was done in this patient. So there is no blood group incompatibility. DCT ICT was negative. For non-immune, there are only 3 possibilities. Either it's a hemoglobinopathy, like someone said alpha thalassemia, but the baby will be hydropic in that patient there. Enzymopathy, that is G6PD deficiency or PKD, pyruvate kinase deficiency, but the retic is sky high. G6PD is the female baby. And membranopathy, again spherocytosis or elliptocytosis, not on day 1, not at birth, okay, maybe after some time, not at birth, and with retic count higher, with the even the MCHC will be on higher side. Now come to the non-hemolytic anemia, then we have to rule out whether there is a blood loss, okay, or there is occult hemorrhage, that's fetomaternal. So we are not talking about hemolytic, we are talking about non-hemolytic. The baby has been investigated, there is no obvious blood loss. So where are we now? Fetomaternal, right? So likely fetomaternal, and when we know this is fetomaternal, then what is this? What is this test called?
So so Dr. Elizabeth has answered fetomaternal and clear Wetke test.
Correct, perfect. So what you can see, this pink cells are the fetal RBCs in against the background of maternal RBCs, right? So this is to know how much fetus has lost the blood volume in the maternal blood, right? So this is the KB test. Are we clear? Okay. Okay, now quick questions. Identify this. Lipti Garima has raised hand.
So all of them are answering band cell.
Perfect. Full marks. Okay, now identify these charts. Look at this, left side, right side, x-axis, y-axis, percentiles. Last question. अच्छा आंसर कर रहे बच्चे.
This is the second last session. They're very close to exams, so I think they're preparing for it. So, yeah, so everyone is saying Monroe's chart.
Perfect. Mosinot chart. Okay.
Mosinot's, yes.
Okay. So the lower chart is for the term baby, and the above chart is for the very low birth weight babies. Good. Very good. Oh, thank you.
Thank you, Dr. Shilpa. It was good. So much information. So let's start. So just to before ending, we still have the PowerPoint presentations.
Yes.
Because they need to be assessed on that also. So Dr. Swapna can, I think, share her screen. So she has tried sharing in between.